They're a middle-aged guy or an older guy with a history of kidney stones, and it's probably a kidney stone. The good thing about kidney stones is 75% of them will show up on a plain X-ray. All of them will show up on a CAT scan, but 75% of them will show up on just a plain X-ray. So if they're in your office, shoot a quick X-ray to see if you can see it. As you can see on this the image on your left. The image on the right, though, is if you have a woman come in, she has the 5 F's, as I recall from anatomy, and she's complaining of right upper quadrant pain after going over to the chicken place across the street. It happens every time. And unfortunately, most gallbladder stones are made of cholesterol, which is radiolucent. So you only have about a 25% chance of finding those. There are gallbladder stones that do contain calcium salts and will show up as little circles, not solid balls like kidney stones do, but your chances are only 1 in 4. So if you're going to if you suspect gallbladder, you're going to send them for another modality and not risk a 75% miss. Understand? Okay. These stones up here, calcium oxalate, that's the most common. The triple phosphate there is the thing you need to know for the board exam is Proteus mirabilis produces triple phosphate stones. So a kidney infection, a chronic kidney infection with Proteus will produce that. Those stones, they tend to grow so large they'll fill up the entire renal pelvis and the major and minor calyces, such that it looks like the horn of an elk. That's why they're called staghorn calculi. They look huge. Those are the things, you know, the pathognomonic staghorn calculi, Proteus, triple phosphate. Okay? Any questions on plain films? Okay, let's use radiation, ionizing radiation a different way and talk about CTs, CAT scan, CTs, computerized tomography, whatever you want to call it. So what they have here is instead of this type of silver impregnated, you always have a cylinder here, and you have a detector much like a digital X-ray. And the cathode revolves around that circle, taking X-rays at different points in the X-ray. So instead of being exposed to 1 shot, you're exposed to 50 shots, and that's why there's so much higher radiation dose. Your computer will take that, what X-rays penetrate and which ones are obstructed, and reconfigures essentially a 2-dimensional slice from that circle. Because it's a computer, you can take all the slices and adjust the setting on the computer and change a transverse view into a coronal section or a sagittal section. You can really manipulate it any way you want to. Now, the thing you're going to see about CTs is they don't, when I mentioned earlier about the 2000, the grayscale of 2000, I wasn't kidding. The grayscale for a CT is called a Hounsfield unit. And it goes from -1000, which is black, to +1000, which is white. That's how many different shades of gray a computer can see, 2000. Now what you want to do is if we set the computer to accept all 2000 shades of gray, what you're going to get is just a gray image. It'll be completely gray. There's no contrast to it whatsoever because the shades vary so little. What you want to do is you want to narrow the window of the Hounsfield units to only about 200, no more than 400, Hounsfield units. So you want to accept a grayscale of a couple of hundred. Everything less than that, just make it black. Everything more than that, just make it white. So what you've introduced into the CT is contrast. And that's what you can manipulate on the computer. You can sit there at the computer and move up and down the Hounsfield units to make it more or less contrasting, to make it the best image possible. When you get CT results back, you're going to see that they refer to, this image was taken with a Hounsfield unit setting of 236. So that's what a Hounsfield unit is. You don't have to tell them how many Hounsfield units to shoot it at. They will do that themselves. But that's what it means when you see that. Okay? Paul.
Can you do that after you shoot it? Like, can you shoot it and then play with the...
You can play, Make it light, dark, gray, black. Yeah, it's just a mouse. It's just a mouse.
I just didn't know if you had to like choose and shoot it and if it's wrong.
Oh, no, it's there.
Thing and it'll look into the image.
It's what?
It's like a sliding, like feature where it's like, it's literally on a...
Over on the side of the screen, it goes up and down. Yeah. And matter of fact, you can actually change contrast on the digital X-ray machine over at Good Shepherd. You can sit there and make it bigger, make it smaller, brighter, lesser, so once these things get digital, you can do anything you want to with them, okay? All right, so this is an example here where they've gone through on a chest X-ray and changed the units considerably. So up here in the top, understand if you were to take this picture with a plain film, you wouldn't see a thing. It'd be just like an empty skull. But this, because of it detects high sensitivity to differing densities, you can pick out that tumor within the dead cerebral tissues of that brain right there. Similar to here, and then similar to here, you just change the setting on the computer, and now you've gone from a transverse view to a coronal view. So, pretty easy to do, okay? One thing about CTs though, when you're viewing CT, is that, like the same thing with the plain film X-ray, you can put it up this way, you can put it up that way. The CT is the same thing, you can put it up this way, or you can put it up that way. Now CTs are always going to be lying down. So you always view images as if you're standing at their feet, looking up towards their head. So in this image here, whoops, uh-oh. Oh, no. Okay. So in this image here, is that the right eye or the left eye? It's the right eye. But it could be the left. All you got to do is turn the image over. Right? So that's, by convention, you always look at CTs as if you're standing at their feet, looking up towards their head. So this is going to be the right side of the heart. Right side of the chest. This is the left side. Voila, there's the heart. And that's another thing. I cannot stand Oklahomans and say, well, how do you spell, anybody here speak French? Anybody speak French? How do you spell voila? V-O-I, right? It's not W-A-L-L-A. It's not voila. That's a fish. A walleye is a fish that's in waters of... You can catch fish, a walleye fish, out at, no, what's that name? New Walleye. Hefner Lake, if you want to. It's not voila, it's voila. Okay. I don't even know what got us off on that track. Okay. The problem is with CT is that they're good for these things right here. They're good for things that are going to give you contrast. Like plain films, for the difference between bones and non-bones, and airspace and non-airspace, and contrasted things like that you see here. They're not good on things with the same density. If you're trying to pick out the tendons at the end of a muscle, that's the same thing. It's the same density. So if you're looking at a joint, it's great for the bones of the joint and for the cartilage of the joint, but it's not good or the tendons of the joint. If you're suspecting an ACL injury, you'd get an MRI. If you suspect a rotator injury, you'd get an MRI. So, okay? Most of the time now, though, orthopedic surgeons will get both, a CT and an MRI. There you go, okay? But if you're particularly interested in soft tissues, particularly with the brain and peripheral parts to a joint, an MRI is the way to go. Now with a CT and with an MRI, you can contrast things with contrast solutions, either the GI tract or the vasculature or both. She had a great point at the break that they don't use she had a provider ordered a CT of the neck because of a mass in the back of the neck, with and without contrast. The radiologist said, no, you're only going to get it without contrast. Why did they say that? Why did they say that? What is the purpose of contrasting a mass in the back of the neck? It's not vascular, it's not GI tract. It's not going to pick up any contrast material. Okay, so you only use contrast if you need it to highlight an area to be able to make a diagnosis of that area or to distinguish it from another area. Okay, this is with CT and with MRI. Okay? MRI, this is the coolest stuff in the world right here, the concept behind MRI actually hit the clinics about probably a decade after CT did, although the MRI was invented before the CT, it didn't make it to medical practice until later. So the thing about an MRI is it uses magnets, not ionizing radiation. So it doesn't hurt you to get 50 MRIs. It will to get 50 CTs. It says it exploits the magnetic properties of elements, and it's based on water. It's based on hydrogen proton, the hydrogen ion, not really ion, the nucleus of hydrogen. It's based on that. If a tissue has more hydrogen nuclei, it's going to be more amenable to MRI. Bone does not have a lot of water. Your brain does. Therefore, the brain is an application, and the spine that I had in the other slide, that's why you use an MRI. It says right here, the quality of the image depends on the amount of water. Okay? It says right here, because it is a magnet, it's contraindicated in people with aneurysm clips or other surgical things implanted, although you should be aware that none of the stuff that's implanted these days is magnetic. So you wouldn't be jerking aneurysm clips off of aneurysms these days. You do need to watch out, though, if anybody has a suspected metallic foreign body in their eye. You don't want that to come flying out of their eyeball. Pacemakers, they will do an MRI on people with pacemakers these days. They used to not do it, but they will now. Okay? You just have to make sure that, and for gosh sakes, take your phone, take all of the electronics, and leave it outside the room, or when you get on them at the end of the thing, they'll be completely blank. So it's a pretty strong magnet. So the way it works is water in your head, for example, is randomly positioned. The hydrogen nuclei in your head they're just drowning in motion, right, all over the place. You're going to apply this magnet, and what it does is it lines up the hydrogen nuclei in a certain, towards the different poles of the magnet. It lines them up. And then what they do is they blast from the side a radio frequency wave that jiggles those lined up parallel hydrogen nuclei off to the side, and then when you turn off the radio frequency, it bounces back. And when it bounces back, it releases energy. And it's the computer that picks up that energy release, and I'm simplifying this horrendously, but it picks up that energy release as a type of radio frequency and puts it into a digital format where you can see it. Okay? And they're beautiful. Now, MRIs they call them T1 and T2 weighted. And you'll see that when you're reading the radiologist report. In this T2 weighted image, you don't really, it doesn't really tell, it's of no consequence to you. It's the finding that's the consequence. But they're going to tell you how they saw it. In a T1 image, weighted image, the fluid is black. In a T2 weighted, it's white. It's just an adjustment on the computer. And you can see it here. The brain is surrounded by cerebrospinal fluid, which is black. So that's how I know that's a T1 image. Over here, this cerebrospinal fluid in the canal is white. I know that's a T2 weighted image. Okay, so a MRI is excellent to use for anything in the brain, for the spinal cord, looking at masses. If you're interested in the vertebra, because of somebody coming in with back pain, if you're interested in the vertebra, you get a CT. If you're interested, if you think it's the spine, you get an MRI. If you're not sure, you're going to get both. But the insurance companies will not let you go straight to an MRI on both circumstances. You're going to have to do first plain films, and you're going to have to do a CT, and then you're going to have to do an MRI. So a CT will cost you, a plain film will cost you a couple $100. A CT of the chest will usually cost you about $600 to $800. An MRI will going to cost you $1,200 on up. Okay, so that's about what you're looking for. You can see in the joints, though, how the ligaments and tendons are well described in these joints. They're pretty impressive. Okay. Ultrasound. Ultrasound is like voodoo. The thing about ultrasound is there are no fixed projections. So when I look at a plain film, a CT, or an MRI, I know from being an anatomist what that is because I'm an anatomist. But an ultrasound, when you take that little transducer and they start moving it around the skin, you can turn it any way you want to. You can point it towards anything you want to. There are no fixed images. The only time that there are fixed images are really in obstetrics. They measure the tibia length and certain things in obstetrics, whereas if you come into the ER and I'm interested in your gallbladder or your kidneys, and it just looks like fuzzy stuff to me, okay? All right, but here's some principles here. It's ultrasound, and it's because it's non-ionizing, and because it's at an energy level that's so low, you can use it in obstetrics. Now, usually they don't, OBGYNs will say that 2 ultrasounds during a pregnancy is the max, but really, there is no max. Usually 2 is all the insurance company will pay for, which is why it's the max. But really, you can do an ultrasound every week if you wanted to check on things. Okay. So it's no harm to the fetus at the energy level that's produced here. Now, the thing about ultrasounds, they're best on soft tissues where you have fluid-to-fluid type interfaces or fluid-to-tissue interfaces like the liver. They're not good on air because the ultrasound can't penetrate. It has to have a medium to travel through, and it doesn't travel through air. And it doesn't travel through bone because you can't penetrate the bone. You cannot do an ultrasound of the cerebrum because you can't get through the skull, okay? A lot of times you'll get an ultrasound of the abdomen, of the liver, the gallbladder, the biliary tree, and you'll get a report back that the pancreas was not visualized because of air in the bowel. Well, now you're screwed. If you think that, if pancreatic cancer is on your differential, you've got a worthless ultrasound study, and you've got to send them to CT now, okay? So you see that a lot of times because the radiologists are experts at limiting their own liability. They'll always say that there's, something is there and cannot exclude, a tumor the size of a watermelon so anyway, you understand what I'm talking about? I'll give you an example. There was a woman, came in to the family medicine clinic where I used to work. She had community-acquired pneumonia. On a scale of 1 to 10, 10 being the worst, hers was probably a 3. But she came in, she was an employee at OU, so I said, well, okay, we'll shoot an X-ray to confirm it. There's no indication for shooting a chest X-ray to confirm community-acquired pneumonia. It's a clinical diagnosis. Nonetheless, I said, you're here, let's shoot a chest X-ray. So we get a chest X-ray, and her pneumonia is sitting next to the mediastinum, like that picture I showed you earlier. So the X-ray report I get back from the radiologist is consolidation in the chest consistent with community-acquired pneumonia. However, because it's obscuring the mediastinum, cannot rule out mediastinal mass.
Oh my God.
Crap. So now I've got to go get a CT on this woman to rule out this radiologist covering his butt, right? So I called her up and I said, ma'am, I hate to tell you this, but I need to get you a CT. There's nothing wrong. I think it's going to be negative. Nothing wrong. It's just, I just got to do it because the radiologist said I need to do it. He didn't actually say I need to do it. He was just covering his own ass, right? So I sent her over for a CT. A CT is a slice, right? A CT is a slice. And when you're doing a CT of the chest, you have to get all the way down to the bottom of the diaphragm. You got to get down to the costomediastinal recess, right? What sits right there? The costomediastinal recesses right there. Your kidneys. I get the CT report back that says everything's consistent with community-acquired pneumonia. However, there is a mass on the superior pole of a right kidney suggestive of renal cell carcinoma. Oh shit. So now I gotta call this lady back again and say, I gotta send you to a urologist because of your community-acquired pneumonia. Turns out it was renal cell carcinoma. And had not everything been lined, had the tumor been on the bottom of the kidney, you would have missed it. It just so happened it was on the top, which is right there at the bottom of the, so, and you get all the way back to the beginning, it all started with my dumb ass taking a picture.
But now he's a genius.
Yeah.
Like, oh yeah, I meant to do that. Yeah. But so that's, anyway, there you go. Okay, so, and a Doppler ultrasonography, what Doppler ultrasonography does is that it, you know, when you're standing out by the train track and you hear the train coming, right? That's the Doppler effect. As it's coming towards you, for those of you that stand out there on the train tracks, drinking the wine, I know, Paul. So, as that train is coming towards you, it's compressing the air in front of it, and that's when you get the like that. So that's the same principle that we have with Doppler ultrasound, and you're looking at the flow of fluid in vessels. If it's going to go this way, and the Doppler will even tell you if it's coming this way or going that way. And it will color things coming this way red, that way blue, or some derivation of thereof. And that way it'll tell you there's an artery or vein, depending on where you are. Okay? We do Doppler ultrasounds all the time of the lower extremities looking for DVTs. And one thing you're going to do is whether or not it's compressible. If you have an artery and you push down on it with the Doppler, with the probe, an artery has such a thick muscle wall, it doesn't compress, it just moves. A vein, on the other hand, if you compress it, you'll actually squish it. So if you're doing a Doppler ultrasound looking for a DVT, the report will come back that they're clear, the veins are clear, compressible, which means that they're open. If they're not compressible, that means they're full of clot. Okay. If you look at some examples here, here's the ultrasound, plain ultrasound of the gall bag. You never use contrast with ultrasound, by the way, showing the 4 rocks that are in there, lined up pretty in a row. Because these things are dense, you look at the shadow behind them. That'll help confirm that, yes, indeed, those are gallstones. Here is a kid, obviously. And here's an example of a Doppler ultrasound showing the 2 vessels. I don't know where that is, but maybe the popliteal area. One of them is the popliteal vein, one of them is the popliteal artery. Okay? My wife calmed me down one time because she was an LPN. They were out there ultrasounding a friend of ours, you know, trying to find out was it a boy or was it a girl. And I get down there and she said, "Are these the testicles?" No, that's the head. A little off. Actually, you don't look for the testicles in making a call between a boy and a girl. What you're looking for is down in the perineum, you look for 3 stripes. So there's the vaginal opening and the 2 labia. You're actually looking for the female body parts, not the male body parts, when you're sexing the child. Okay? Huh?
That's what it's called.
Looks like a turtle. I'm not going to go there. All right. Any questions about any of that? All right. One other thing here is called radionuclide imaging. And what you do here is you're taking advantage of different tissues to take up certain chemicals, compounds. Iodine, the thyroid is the only organ that takes up iodine. So if you take that iodine molecule and radio label it with something, a lot of times it's with technetium-99, you inject it, a few hours later it's going to wind up being concentrated in the thyroid. That's a thyroid scan. You can do the same thing with a bone scan, or there's a thing that they used to do a lot before they were replaced by CT. It's called a ventilation perfusion lung scan. That's how you would diagnose a pulmonary embolism. They would inhale xenon gas, radioactive xenon gas, and that'll give you an outline of the airways of the lungs. And then they would inject a intravascular compound that was radioactive, and that shows you the vascular distribution of the lungs. Well, if you have a pulmonary embolism, you would have a mismatch between the aerated parts and the blood supply parts, and that was confirmation that you had, that was a definitive confirmation that you had a pulmonary embolism. It was called a VQ scan. I don't know if that's up there or not. I don't know for what reason they would do it like this. They put a little dot over the V and a Q, a VQ scan, ventilation perfusion lung scan, but now they do just plain CT. We'll get you that, with contrast. We'll get you that, okay? Now this stuff that they're injecting into you is radioactive. It has, so they put you in a essentially a gamma counter, Geiger counter, and it picks up the radioactive decay and gives you a picture of it. Now a person having a thyroid scan, a friend of mine gets thyroid scans all the time because he has thyroid cancer, keeps coming back. But he has these thyroid scans all the time, and when he gets a scan, you can't eat after him, you can't share utensils, because what he's put in his mouth, you don't want the, well, you wouldn't want to put it in your mouth anyway, but you can't ride in a car with him because of proximity, and he has to stay away from reproductive age women, all for about, I can't remember, it's like 3 or 4 days, until the half-life of the radio tracer is gone. So, there you go, okay? Now the problem with this is, oh, it's a short half-life, hours to days. The problem with this is that results in poor spatial resolution. Now you can see here, that's obviously poor spatial resolution. Another study though, let me tell you about, is if you're interested in, if somebody's bleeding, if you're bleeding and no one knows where you're bleeding, if you're just losing blood chronically and nobody knows where it's going or where it's leaking out, they will draw your blood and tag the red cells and inject them back into you, and wherever it's coming out will show up on a scan. Okay? So here's the type of image you're going to get. This is a bone scan right here. You get diagnosed with cancer, you're going to have a bone scan. 100%. You're going to have a bone scan. Metastatic cells to bone have a higher metabolic rate than the bone does itself, and so you're taking advantage of that as a greater pickup of whatever you're injecting. A lot of times it'll be radioactive dextrose. But you take a Geiger counter type image here, a gamma counter, and you can see that the knees here are showing up like that. What's this person's problem? It's what? Not arthritis. Arthritis is an inflammatory process. It's not going to show up as a positive.
Osteoporosis.
I heard somebody say, what? Osteogenic. Not osteogenic. It's the fact that osteosarcoma. Remember we talked about an anatomy? Did we talk about anatomy? Osteosarcoma being involvement of the knees mostly. Notice that this stuff gets filtered by the kidneys. So you got the kidneys will show up and it's deposited in the bladder. There you go there. This image over here is called a thallium scan. What they do is they inject radioactive thallium that gets concentrated in the heart muscle. And they exercise you. And if you have dead heart tissue, scar tissue from MIs and whatnot, you're going to have a filling defect on a thallium scan. It's a wall motion problem. Let's see where you can see here this nice perfect U but you don't see that up here. So the apex of the heart of this person is touched. Okay. Anything else we need to talk about? All good? Okay. All right. I'll see you guys Thursday when we talk about neoplasia.
Do you have to say it like that?
See you on Thursday.